Now, moving on to the different IIM manifestations, which I briefly covered earlier. So on the left, where I've put domain, you can see the different manifestations. So myositis, interstitial lung disease, ILD, cardiac involvement, skin involvement, and esophageal involvement as well. Now, what symptoms can these lead to? Well, these can lead to many, many different symptoms. This means that our patients, they may present to many different doctors. So they may present to their primary care physicians, the dermatologists, the respiratory physicians, the neurologists, the cardiologists, the gastroenterologists as well. So the myositis, understandably, will lead to myalgia, proximal limb and neck weakness as well. Interstitial lung disease, understandably, shortness of breath, cough. They particularly have non-specific interstitial pneumonia as well. Cardiac involvement, a lot of patients don't have symptoms. I'm going to come on to this a bit later. It can lead to chest pain, palpitations, exertional dyspnea as well. Skin involvement, really important to associate if this is related to sun exposure. Typically, people with dermatomyositis have their rashes in the sun-exposed areas of their face, their neck, the back of their neck as well. And it's always important to consider the nail folds as well, which I'll talk more about in a bit. Esophageal involvement, typically, again, it isn't reported unless you particularly ask. People say that it's difficult to swallow food, they have to cut their food smaller, into smaller pieces as well. And this is a typical sort of referral that we see, especially in the UK as well. So, dear doctor, many thanks for seeing Mrs. Jones, 70-year-old female. She developed a skin rash, proximal muscle weakness 8 months ago. Creatine kinase, which is a muscle enzyme, was raised, so markedly raised at 4,250. An MRI demonstrated myositis in the thigh muscles, and a CT scan demonstrated features of low-grade interstitial lung disease too. So they've done quite a good workup. And she tested positive for anti-NXP2, which is a myositis-specific autoantibody, which we'll talk more about later. She's already been started on steroid therapy, initially prednisone 40 milligrams once a day, and she has responded well. So, what are we actually going to do in clinic? We have a lot to talk about, we have a lot to examine, we have a lot to consider how we're going to manage. And these are the 4 things that I always think about. So firstly, we need to clarify the diagnosis. We need to quantify the disease activity. We then need to quantify the disease damage. And then finally, we need to identify factors that may impact how we manage them. Once you've clarified all of these, you can then form a really focused and personalized management plan. So going back to the different domains, myositis, ILD, cardiac involvement, skin, esophageal, it's always important to consider asking lots of different questions to cover all of these domains in the history, which we covered earlier as well. And then moving on to examination. So manual muscle testing, MMT, for the myositis, and it's really important to quantify the muscle strength. It's important to do it at baseline, so then we can identify any changes in future. How are we going to investigate myositis? Well, MRI scan. So MRI scan can identify the presence of myositis. It doesn't tell us why it's there. Nerve conduction studies and EMG, again, this can identify features of myositis, can potentially differentiate between causes of weakness. It might be that someone has actually a condition that means that they have reduced nerve supply. They may have multiple sclerosis. There may be another pathology that the nerve conduction study can actually indicate, actually we need to think about a different diagnosis. Biopsy, this will give us really important pathophysiological information. This can identify some of the changes that I mentioned earlier, especially identifying necrosis and an inflammatory process. CK, creatine kinase, is a muscle enzyme, which is typically raised in myositis. You can also use ALT or aldolase as well, depending on what your lab can test for. Now, interstitial lung disease. On examination, I always listen for crepitations. It's always good to identify this. Can I identify that they may have antisynthetase syndrome as opposed to another subtype? Chest x-rays, CT scan, and pulmonary function tests are key here. For cardiac involvement, now, it's always difficult to assess for subclinical cardiac involvement because a lot of patients may have a small degree of cardiac involvement that may not be symptomatic. But it's always important to assess at baseline features of cardiac failure and to note their absence. We always measure a troponin I. This is cardiac specific. A troponin T can be raised if someone has peripheral limb myositis, but a raised troponin I specifically identifies cardiac involvement. An ECG and an echo, obviously to quantify the function as well. Now, in terms of skin examination, if you have time, it's great and comprehensive to do a top-to-toe skin examination, particularly looking for some of the skin manifestations that we're going to talk about a bit more later. It's also important to identify, to examine people's backs. They typically don't look there, the back of their thighs as well. Photography is really important, so getting really nice clinical photographs so you can compare the change in future. Biopsy, if someone maybe doesn't want to have a muscle biopsy, if there's this area of skin involvement, it's good to biopsy that, and that can give you some key diagnostic info. Capillaroscopy is really key as well. It's always important to really identify if there's any dilated nail file capillaroscopies on examination, but also capillaroscopy as well. Esophageal involvement, difficult to examine this, obviously. If you think someone has esophageal involvement, an OGD endoscopy can help. Dynamometry, if available, can also help quantify as well. And then other miscellaneous investigations, test for myositis-specific autoantibodies or associated antibodies, which we'll talk more about in a bit. So manual muscle testing, we use the 10-point scale. Now, we use isometric testing, so you want a patient to take a position and you want to press against that. You're not asking the patient to move against you. Now, this goes from 0 all the way up to 10. 10 is normal. So 10 is where they hold the test position against strong pressure, all the way down to, for example, 6, where they hold the test position against slight pressure. 5, they're holding the test position against gravity. In 4, they're holding the limb position and they're against gravity, and then they're gradually releasing it. In 3, there's just they're moving through a partial range of motion. 2, they're moving through a complete range of motion in the horizontal plane. So when you're taking gravity out of the context here. 1, they're moving through a partial range of motion in the horizontal plane. And then if you're going down to T, only the tendon is becoming prominent. 0, there's no contractions. I'm going to put this in context. So there are 8 different muscle groups we test. Now it's important to note on number 6 there, we're testing neck flexion. Now we're only testing that once, so you get a score out of 10. The other 7 muscle groups we're testing on both sides, so you're getting a total score of 150. So the 7 muscle groups, both sides you're testing out of 10, so that gives you a score out of 140. Neck flexion adding another 10, so it's out of 150. 150 is normal, anything lower than that is weak, and it's good to quantify this. Obviously there's a lot of variation between different examiners, but it's good to quantify it. Now, how do we quantify disease activity and damage? There are 6 different domains according to the IMAX core set measures. Now, for activity, you can see in the middle column there, we're going to measure the patient global, 0 to 10, 10 being high disease activity. Physician global, again, 0 to 10. Muscle strength, which I've just spoken about, a score out of 150. Muscle enzyme, so CK. Extramuscular global, so you can use a global VAS, 0 to 10. Higher for more extramuscular manifestations, be that interstitial lung disease, skin involvement, cardiac involvement. And the function is the HAC. This gives you a functional score between 0 and 3. The higher it is, the more functionally impaired they are. Damage, we measure a number of similar parameters here. We don't measure a muscle enzyme because people who have marked damage may have a completely normal muscle enzyme. If they don't have any myositis but they have a lot of damage, their CK may be normal, and this could be falsely reassuring. We use something called the Myositis Disease Damage Index, and the other parameters are the same as before, but measuring damage. So putting this in context with a patient, so you can see for their disease activity, they may give a score, a patient global of 8 out of 10. The physician may give a score of 7 out of 10. Their muscle strength is reduced at 142. Their muscle inflammation is raised at 4,250, and the extramuscular globule is 4 out of 10. Their function is slightly impaired. You can see that we can use these in the damage as well. We can use the myositis disease damage index, which gives a score between 1 and 10 as well. But how do we use these? So it's really good to use these serially over time. So I always measure all 6 of them every patient visits, then we can measure them every time. It gives a quantifiable progression, response to treatment, etc. So we can see if we enter this patient's information, this is the ACR-EULAR criteria for minimal, moderate, and major clinical response in adults. You enter the IMAX core set measures. So here we can see in the middle the baseline scores, and then at follow-up, whatever time interval this is, we can see that they've changed. So, for example, the physician global disease activity has gone from 7 down to 5. The manual muscle testing has improved from 142 to 148. The extramuscular disease activity has gone from 4 to 1. That's improved. The CK is reduced from 4,250 to 2,182. Putting it into the web calculator, we can see that this patient has had a total improvement score of 60, which constitutes major improvement. There's also the thresholds higher than 40 for moderate improvement, higher than 20 for minimal improvement.
Which members of the MDT, the multidisciplinary team, are important to manage myositis?
Yeah, so I'm going to go back to the slide here. So yeah, so we can see all these different domains. There's loads of different manifestations here. So, and every health service is different. Which other members of the MDT are available is going to be different for everyone. But we tend to involve our respiratory colleagues, our dermatology colleagues, our cardiology and gastroenterology colleagues where appropriate. We work closely with our physiotherapists. We may end up talking about this later, but physiotherapy and exercise is a mainstay of treatment. We know that exercise is safe at any stage of myositis. So early engagement with physiotherapy is really important. If you have a specialist physiotherapist, then that's fantastic and will really help the patients. Our occupational therapists are excellent as well. So our patients are at increased risk of developing, seemingly trivial but really serious conditions like tenosynovitis, for example. And it's really important that we give people occupational amendments that may impact their function, their working ability as well. So our podiatrists are really important as well. Some of our patients who have muscle damage develop unequal weight bearing, and involving the podiatrist early on can maintain excellent posture, reducing the risk of developing secondary osteoarthritis, for example. So it's a real team game. The clinician at the center looking after the care has to coordinate care with lots of other members of the MDT.